Morning and good afternoon to all others who are joining from rest part of the world. Today, our guest speaker for the day is no other than Dr. M.B. Agarwal sir from Mumbai, India, and he is going to lecture us on smoldering multiple myeloma, observation versus control versus cure. This webinar, as usual, is brought to by Mumbai Hematology Group, supported by Jensen, Unipath, Lucian, and Nirvin Life Sciences, and managed by Perfect Square. I thank Team Jensen, Unipath, Lucian, and Nirvin, Mr. Yash, Mr. Kalpesh, and the team Perfect Square, Executive Committee of Mumbai Hematology Group. Our guest speaker for the day, Professor Dr. M.B. Agarwal sir from Mumbai, India. All our discussants who are themselves very eminent hematologists as well as medical oncologists, and you participants for spending your Saturday evening, morning, or afternoon from whichever part of the world you're logged in. Tomorrow, that is Sunday, 23rd of February 2025, from 11:30 a.m. Indian Standard Time and 6 a.m. UK time, we have again Dr. Shankara Padisha from Birmingham, UK, speaking to us on mantle cell lymphoma treatment landscape in 2025. Let me introduce our discussions for the day, and they are displayed here. To start with, we have Dr. Abhijit Ganapur Pule from Dr. Abhijit Ganapule from Kolhapur, Dr. Anil Sharma from Gwalior, Dr. Ankur Jain from Delhi, Dr. Arun VA from Mumbai, Dr. J.M. Khungar from Delhi, Dr. K.K. Radhika from Hyderabad, Dr. Kunal Goyal from Mumbai, Dr. Kundan Mishra from Lucknow, Dr. Mallikarjun Kailashetty from Bengaluru, Dr. Nilesh Vashekar from Nashik, Dr. Pradeep Kumar from Delhi, Dr. Raghavendra Rajeshwarkar from Barshi, Dr. Sanjeev from Lucknow. Now it's the time to introduce our guest speaker for the day. We have no other than Professor Dr. M.B. Agarwal sir from Mumbai, India. Dr. M.B. Agarwal is Professor and Head, Department of Hematology, Bombay Hospital Institute of Medical Sciences, Marine Lines, Mumbai, India. He requires no introduction, but it's my duty to introduce Professor Dr. M.B. Agarwal sir. He's an honorary hematologist at PD Hinduja Hospital, Lilavati Hospital, Fortis Hospital, Breach Candy Hospital, Mumbai. He is the president of Mumbai Hematology Group from 2025 to 2026, past president, Indian Society of Hematology, 2010 to 2011. His major contribution in the field of hematology is in the field of education. He has published a yearbook in hematology called Hematology Today, which used to be a multi-author venture containing 60 to 70 chapters based on recent advances in the field. This book was published every year from the year 2005 till 2018. He has got keen interest in clinical research, and his original contributions are in the field of multiple myeloma, chronic myeloid leukemia, iron chelation, antiphospholipid syndrome, and acquired coagulopathies. In the last 40 years, he has published over 120 original articles in various international and national journals. He has received 40 orations and various awards from the national and international bodies. He is also the advisor to government of Maldives, Sri Lanka, and Bangladesh for community control of thalassemia. He has been advisor to Medical Council of India and Maharashtra Medical Council for developing guidelines for management of various hematological disorders. He has been an examiner for postgraduate course, DM course in clinical hematology, hematopathology, medical oncology, as well as transfusion medicine at various universities in India. He has been an inspector for recognizing various departments of hematology and transfusion medicines for postgraduate courses by Medical Council of India and Maharashtra Medical Council. He has organized various international events in the field of hematology in India, and this include Essence of ASH, Essence of EHA, Essence of ICML, Lugano Meeting on Lymphoma, Annual Conference of Indian Society of Hematology, and Mumbai Hematology Group. He has been invited as a guest speaker by various neighboring countries, including Bangladesh, Nepal, Sri Lanka, Maldives, Myanmar, Malaysia, Singapore, Thailand, Cambodia, Philippines, China, Russia, Middle East countries, and also by TIFF, that is Thalassemia International Federation, for the annual events. Beginning with the pandemic, he has been instrumental in arranging online learning by conducting webinars on every Saturday evening and Sunday morning with best of the international faculty. And to tell you that these webinars continue, and by now it has crossed a number over 400. Today, He's going to lecture us on smoldering multiple myeloma, observation versus control versus cure. Well, thank you so much. I stop over here. Dr. Agarwal sir is not currently, will be presently over here. So there is a pre-recorded lecture and we'll play his pre-recorded lecture on smoldering myeloma. Uh,
Well, good evening to everybody from India and good morning or good afternoon from those who are logged in from the rest of the world. Today, the MHG webinar is on smoldering multiple myeloma. Well, smoldering multiple myeloma is a story of last 45 years, as the term was first coined way back in 1980. What exactly does the word smoldering mean? Smoldering means to burn very sluggishly, without flame, and often with a lot of smoke. And that is what is depicted here. And the smoldering myeloma is something which is without flame, which is not very aggressive, which is relatively a milder entity and does not have clinical counterpart as such. So we use four major terms when we're describing about plasma cell dyscrasias: the MGUS, the smoldering myeloma, the overt myeloma, and the plasma cell leukemia or other extramedullary plasmacytomas. It begins with initiation of the tumor, and then the tumor evolves. There is an influence of the immune microenvironment, and patients can develop drug resistance. And this is all story of genomics, proteomics, transcriptomics, and the epigenetics. How do we define MGUS, smoldering myeloma, and the overt myeloma? So this cartoon tells us all. So the top you see here the title MGUS. And MGUS means the M protein is less than 3G per DL, and the bone marrow plasma cells are less than 10%. In the smoldering myeloma, this M band or the M protein is more than 3 gram per DL, and the bone marrow plasma cells are more than 10%. And then you have this myeloma, which is initially used to be described only if the CRAB is present, that is hypercalcemia, renal failure, anemia, and bone disease. But during last 1 decade, we also include those patients as myeloma who have biomarker abnormalities, in the sense plasma cells are more than 60%. The FLC ratio is more than 100, involved to uninvolved chain. And MRI shows you 2 or more focal lesions. So there's no doubt that all these patients need treatment of myeloma. MGUS does not need treatment. And for the smoldering, we will see today what we do in these patients. So to expand the definition of smoldering myeloma a bit more, so you should have the monoclonal IgG or IgA more than 3G per DL, or the urinary monoclonal protein should be more than 500 mg in 24 hours. And all this may be associated with bone marrow plasma cells between 10 to 60%, or there may only be bone marrow plasma cells between 10 and 60% in a non-secretory situation. And these patients should not have any myeloma defining event. And we just saw what they are. And these patients should not have amyloidosis. So now we are clear what SMM means exactly. How do you diagnose a patient and call that patient as SMM? Now, what is the exactly epidemiology of the SMM? And the best probably data comes from the iSpot multiple myeloma study from Iceland, published very recently. And it tells you that 0.5% of the individuals above the age of 40 years fit into the criteria of smoldering multiple myeloma. There's also data from the same study to show you that SMM has increasing prevalence as the age increases. As you see in these two curves, from 50 years to 90 years, the prevalence of SMM keeps increasing. And what this study also showed is that the number of males outnumber those of females. Now let's look at the biological events which are connected with progression of plasma cell dyscrasia for normal pre-germinal B cell to the precursor cell to a myeloma cell which is in the marrow and to a myeloma cell which is outside the marrow, the extramedullary myeloma. The very early events in the genesis of a plasma cell dyscrasia are related to primary IGH translocations, hyperdiploidy, and deletion of chromosome 13. Subsequently, there are changes in NRAS and KRAS, together with secondary IGH translocations. And then there is MYC gene upregulation or MYC rearrangement, and also the changes in P53 and other genes. This is how a patient progresses. I'd like you to concentrate on the bottom part of this slide. It's extremely important to realize that it's not just the plasma cell that defines what's happening to a patient, but also what's happening in the microenvironment of the bone marrow. And there are a couple of very important things that are happening in the genesis of myeloma. The osteoclast activation, the osteoblast inhibition, increased angiogenesis, and altered expression of cytokines, growth factors, and adhesion molecules. It's ultimately the interplay between the plasma cell changes that are taking place and the changes taking place in the microenvironment that decides where the patient will stand. If you compare the genetic alterations in SMM versus overt myeloma, then as you see in this study, whether you're looking at the copy number alterations as depicted in orange, mutations as depicted in the dark green, and translocations as shown in the light green. All of these genetic alterations are much more in a newly diagnosed myeloma than in the smoldering myeloma. You look at the evolution of the disease from the smoldering myeloma, the M protein may gradually increase over years, or the M protein may rapidly increase in a short period. This tells you that SMM is not a homogeneous disease. The patients can have different trajectories. So you have MGUS here, smoldering myeloma in the center and overt myeloma on the right side. Approximately 35,000 new cases of myeloma will be diagnosed each year in US. Now what happens at the level of MGUS, which is relatively a homogeneous entity, is 1% of patients of MGUS would develop overt myeloma every year. Now SMM is much more aggressive, where 10% of patients would develop overt myeloma, at least in the first few years. And that's what is shown over here, that the smoldering myeloma in blue, the number of patients who will develop overt myeloma is larger and rapid with compared to the one in the yellow at the bottom, which stands for MGUS. And as you see in MGUS, 5 years, 5%, 10 years, 10%, 15%, and 20% of patients will develop overt myeloma, as against smoldering myeloma in 5 years, almost half the patients will develop overt myeloma. And then, of course, it recedes and then it becomes very flat. So if you look at the 3 parts of the curves of SMM, the initial one here, the one in the center, and the one on the end, this part is almost like MGUS. So there are patients of smoldering myeloma who behave like MGUS. There are patients of smoldering myeloma who behave with a very aggressive nature. And there are patients in between who are probably the genuine smoldering myeloma. So the rate of transformation is non-linear. It's highest in the first 5 years, where it is about 10% every year, 50% at the end of 5 years. Or it can be extremely low, as you saw on the right half of the curve, just 1 to 3% per year. So once again, that is shown over here, that these are patients who have relatively aggressive myeloma, 10% developing, I mean aggressive smoldering myeloma, so 10% developing overt myeloma every year. So the slope of the curve is very different. And this is MGUS-like, so only 1-2% developing myeloma every year. And then you have in between where it is neither 10% nor 1%, but in between. So this is probably true smoldering myeloma. This is high-risk myeloma. This is very low-risk myeloma, or almost akin to MGUS. So if you have these 3 trajectories, then it's extremely important that when you see a patient on day 1, you should have some kind of understanding that what is the risk of this patient to develop myeloma rapidly, slowly, or not develop at all. So based on this, SMM can be called low-risk SMM, intermediate-risk SMM, and the high-risk SMM. So what are the commonly used risk stratification models in the clinical practice? So there are at least 2 very popular models which have been around for quite some time now. So these are the Pathema model and the Mayo Clinic model. The Pathema model is the Spanish model and the Mayo Clinic is the US model. These 2 models are based on very different criteria, and that's very interesting. The Pathema model is the older one, almost 1.5 decade old. It is based on the multi-parameter flow cytometry of the marrow plasma cell. And it tries to define the risk of smoldering myeloma based on the aberrant plasma cell versus the total number of plasma cells. Now, how do you define these aberrant plasma cells? So normally plasma cells expresses CD138 and it intensely expresses CD38. The aberrant plasma cell will have decreased CD38 expression. It will have aberrant expression of CD56, and there may be absence of CD19 and or CD45. So you are looking at all these as the aberrant plasma cells, and then the ratio of that to the total plasma cells. So what the Pathema model tells us is those patients who have more than 95% as the aberrant plasma cells are the highest risk smoldering myelomas. The second parameter the Pathema model takes into account is the uninvolved immunoglobulins level. So if it's an IgG myeloma, then they are looking at the IgA, IgM, and so on. So immunoparesis, that means lowered level of normal immunoglobulins, is the other criteria to define the high-risk myeloma. So overall, there are two criteria: the aberrant plasma cells and the presence or absence of immunoparesis. So that is how you score the Pathema score. So if you have more than 95% aberrant plasma cells, score of 1. And if you have immunoparesis, the score of 1. So if both are absent, then this will be a myeloma which smoldering myeloma, which is closer to MGUS. Well, if you have both the scores, 2 score, then these patients will rapidly, within about 2 years, develop over to myeloma. And if you have a score of 1, then it is in between. It will take 6 to 7 years. Now, coming to the Mayo Clinic model, which is relatively recent, 2018. This focuses on the plasma protein, including serum free light chain assay, and the absolute number of plasma cells in the marrow. So it's relatively easy and more sort of available to everybody in all the countries. And therefore, it's more popular. It's also known as 20-20 risk score. So 2 stands for more than 2 grams of the M-band. 20 is more than 20% or more than 20 free light chain ratio. Again, involved to uninvolved, the ratio being more than 20. And the last 20 is more than 20% marrow plasma cells. It doesn't talk about aberrant or over. It's the total plasma cells, 20%. So the formula is popularly known as 20-20. So once again, all these 3 criteria are given a score of 1 each. And those who have the score of 2 or more are likely to progress to overt myeloma, half the patients in 2 years and 80% of patients in 5 years. While those who do not have all the 3, so 0 score, even at the end of 5 years, only 20% will develop overt myeloma, 80% will not develop. Now, unfortunately, both Pathema model and Mayo Clinic model, I would say, a little obsolete because they did not consider the genetic abnormality of the plasma cells. So this genetic abnormality of the plasma cell was taken into account by International Myeloma Working Group, IMWG, and that score came 5 years ago in 2020, where besides FLC, M protein, bone marrow plasma cells, they also took into account the FISH abnormalities, T414, 1416, 1q gain, deletion of 13q or monosomy 13, and gave it a substantial score of 2 there. With IMWG scoring, if you have very high score, there is more than 12, then almost 70% patients in 2 years and 85% of patients in 5 years will develop overt myeloma. While if you have very low score of 0 to 4, only about 4% in 2 years and 20% in 5 years will progress to overt myeloma. So you can see within the smoldering myeloma, you have such a heterogeneity, as you just saw with the working group classification, the low risk, the intermediate risk, the high intermediate risk, and the high risk. Huge difference in number of patients who will go on to develop overt myeloma after 2 years or 5 years. Now, although the working group classification and the staging took genetics of myeloma FISH study into account, but still all these predictive models are very, very inaccurate. You saw that all of these are plasma cell centric, and they fail to take into account the role that is played by the environment of the marrow, which ultimately controls the proliferation of the plasma cell. And although fish is included, the real genomics of the plasma cell is also not taken into account. So there are now studies published in last 2-3 years talking about the whole genome sequencing to decide between the progressive and the stable myeloma precursor conditions. And based on genomes, the two are entirely different type of smoldering myeloma that will progress or not progress. And this is another study where the genetic subtype of smoldering myeloma has been shown to be distinctly associated with pathogenic phenotype in the clinical outcome. Now, based on the molecular abnormality in the plasma cell, there is a cluster classification of SMM. And this is that cluster classification, cluster 1 to cluster 6. Reminds you of DLBCL, isn't it? And then they risk score it, intermediate, high, 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 low, and intermediate risk. So genomics has become extremely important in giving you the risk of evolution to overt symptomatic myeloma in a patient of smoldering myeloma. Of course, this is not widely available and hence it's a research tool only. Well, after having seen the risk stratification, let us come to how you will follow up a patient of smoldering myeloma. So irrespective of whether the risk is low, intermediate, or high, you need to follow up these patients every 3 monthly. But the type of test you will do at 3 months or 6 months versus you will do in 1 year are different. For example, the tests which you will do least are the PET scan and the bone marrow examination, including aspiration biopsy and the FISH, which are done at 6 months to 12 months interval or only when they highly suspect the risk of progression. Most of the other tests you will do at 3 months and 6 months. Now let's come to the management, which is probably the most important aspect of our presentation today. A lot of questions in your mind, like patients of chronic lymphocytic leukemia, like patients of follicular lymphoma, like patient of nodular lymphocytic predominant Hodgkin lymphoma, and many other conditions in hematology. When the disease is not curable, a question comes whether you should just wait and watch. And it's also important that while waiting and watching, which is a careful watching, and we just saw what kind of follow-up investigations are required, these patients should not develop by oversight myeloma bone disease or myeloma renal disease. And that goes unnoticed. So that shouldn't happen. Also, the question is whether by intervening by some myeloma specific treatment, whether you can postpone the occurrence of overt symptomatic myeloma, or whether you can increase the overall survival of patients of myeloma, or maybe very, very optimistic view, whether you can cure myeloma. So if you are a researcher, what will be there in your mind are these factors. Can I cure myeloma if I intervene at the stage of smoldering? Can I increase the overall survival if I intervene at the level of smoldering? And of course, it makes very common sense that you can increase the progression-free survival or the time for the overt myeloma to develop by intervening. At the same time, the question that may come in your mind is, will you be over-treating some patients? We just saw that the low-risk smoldering myeloma is like MGUS. And we also saw that almost 25% of patients may never develop overt myeloma, even at the end of 25 years. So if your risk classification is not perfect, then you will be exposing some patients to drugs with their morbidity, affecting the quality of life, who otherwise probably would have died of some unrelated disease after decades and never developed myeloma. Not only that, by exposing them to drugs, you're making them resistant to the drug when they really need a particular drug. Also, then these patients may never be eligible to be enrolled into the clinical trial, which require patients who are de novo. So there are a lot of questions in your mind when you talk about the management of smoldering multiple myeloma, and I accept that there is no consensus here. But let us see a broad outline and let us see what the hematologists around the world do. So one thing is very clear, that there is no single way to go ahead. That you diagnose smoldering multiple myeloma, protein more than 3 grams, plasma cell more than 10%, or you've got urinary monoclonal protein of 500, do this. The realistic picture is like this. There are various ways, from waiting and careful watch to monotherapy with, say, lenalidomide, to dual agents like lenalidomide and dexamethasone, to aggressive treatment like overt myeloma using triplet or quadruplet. We are in the era of immunotherapy, so daratumumab monotherapy. And you could also talk about going on to do autologous transplant for this patient, or using, say, bispecific or CAR-Ts, because you want to cure them, you want to nip in the bud, and you want to get out of the disease totally. But for this, you need data. You not to document that, yes, you are able to cure or you are able to increase the overall survival, and that you will not harm some patients by unnecessary treating. Curative attempt with CAR-T and bispecific, you know, are at what cost? Some patients may die of the treatment, like infections or second malignancy. Should you do for that for a patient, for a disease where 1/4 of the patient may never need treatment? So here you have lenalidomide monotherapy versus observation arm by Sagar Loniel, Vincent Rajkumar, and others, published 6 years ago, JCO. And here you have the doublet, lenalidomide with dexamethasone, the European study published by Maria Metios and her group. Let's look into this study, because this is probably one of the most popular model. Because the control arm was observation, I think it is very easy to understand that freedom from progression to symptomatic myeloma, there was significant difference with p-value of 0.001 and hazard ratio of 0.18. So the treatment arm did wonderfully well with compared to observation arm, if you're talking about the freedom from progression to symptomatic disease. Well, this study also tried to show you the overall survival. And they showed you that the treatment group had overall survival superior to the observation group with a p-value of 0.03 and the hazard ratio for death 0.3. And this is overall survival since diagnosis of smoldering myeloma, once again showing you the difference between observation group and the treatment group, p-value 0.02, hazard ratio 0.28. Looks nice, looks impressive, but there are limitations. If you go into the depth, this study is a very old study. The enrollment started 1.5 decades ago. One, the sample size was very small. Two, there were inclusion of patients who by present criteria are symptomatic myeloma. So these are patients who had plasma cells between 60% and above, or between 10 and 60%. So they qualified from today's standard the biomarker positive myeloma or the slim myeloma. Now that time, at that stage, when the enrollment was taking place in this trial, the slim criteria didn't exist. And those patients were considered as ultra high risk smoldering myeloma. And the third and the most important part is when they talked about overall survival, it lacked the statistical power to analyze the effect on overall survival. In fact, there's no study till today that has distinctly shown an advantage with respect to overall survival while treating SMA. One of the things I talked to you about treatment is monoclonal antibodies. So we here have the Centura studies. It's a study which has gone on for 7 years. And if you look at the conclusion, it continues to demonstrate the clinical activity of DARA monotherapy in patients with intermediate and high-risk SMM. Almost 7 years of follow-up, and there have been no new safety concern. So these are patients of smoldering myeloma. %50 patients with high-risk SMM can progress within 2 years to multiple myeloma. The standard treatment of SMM is monitoring, active monitoring, wait and careful watch. And when there is myeloma, then you treat. And despite the risk of progression, at the moment, there is no approved treatment for MM. This is the background on which this trial started with DARA monotherapy. This is multi-center randomized open label phase 2 study where intermediate or high-risk smoldering myeloma patients were included. There were 3 arms. And they received long intense therapy with DARA, short intense therapy with DARA and intermediate. And they're looking at the complete response rate or progressive disease or death rate per patient year. And the outcome was positive. And the outcome was positive in all 3 arms. Now, this is Aquila study by Dimopoulos, the Greek study, the DARA versus active monitoring for high-risk smoldering myeloma. Now, DARA monotherapy was associated with a significantly lower risk of progression to active myeloma and significantly lower risk of death. And there was higher overall survival than the group which was only monitored. And there were again no safety concerns. So the takeaway was that DARA monotherapy gives a superior overall response rate of 63.4% compared to only 2% in the wait and watch group. It significantly improved the progression-free survival and overall survival of high-risk subjects, reducing the progression or death risk by 51%. So that's impressive data. Same data from the Aquila study was also presented in European meeting just last year. Subcute DARA monotherapy for patients of high-risk smoldering myeloma. And this is one study where triplet regimen has been used for high-risk smoldering myeloma. So we saw from len monotherapy to len-dex, 2-drug combination to monotherapy using DARA immunotherapy and now triplets. If you go to the clinical trial website, there are 54 interventional trials that have been listed. 54. However, only few of these have been published. All these trials are looking at the response rate. Some are looking at the MRD. Most are looking at progression-free survival, which includes progression to myeloma. The aim of almost all the studies to delay the occurrence of organ damage, that is bone disease or the kidney disease. Many of them are randomized trial, comparing the experimental arm to either observation or the Lendex. Lendex has become the standard for all these trials. Interestingly, there are two academic trials which are single-arm phase 2 study, which are very aggressive, which include autologous transplant, like the Spanish CESAR study. Now, there is no doubt that in all the published trials to date, the response rate and the progression-free survival was successfully achieved. It's understandable because the control arm on majority of them was observational. And even if it was Lendex, then the experimental arm was more aggressive. So you are bound to achieve the endpoint like better response rate and better progression-free survival. So the problems with all these trials are threefold. One, the endpoint are totally misleading. They are not looking at the overall survival benefit. And if they looked at it, the studies are small and they do not have statistical power. Now, patients with truly high-risk SMM who really need probably intervention, they will progress one day to overt myeloma. And at that time, they will be refractory to the drugs that they have used upfront. It may be Len, it may be Lendex, it may be Dara, but they will be refractory to that drug when they really need effective anti-myeloma drugs. And if some patients are incorrectly put into the high-risk category and they were not high-risk category, then they got all the toxicities of the treatment, the medical toxicities, the financial toxicities, and they may not get any survival benefit whatsoever. So what are the present guidelines for managing smoldering multiple myeloma? I can only use the word guidelines because there is no FDA-approved protocol for smoldering myeloma. So if you take MGUS and smoldering myeloma together, and you risk stratify MGUS into low risk, intermediate to high risk, and smoldering myeloma into low, intermediate, and the high risk, then you'll see it is wait and watch for low risk MGUS, wait and watch for intermediate to high risk MGUS, wait and watch for low intermediate risk smoldering. When it comes to high risk, it can be wait and carefully watch versus enrollment in the clinical trial versus starting treatment with either Len alone or Lendex. This is what the guidelines tell you. More guidelines. So if you have myeloma symptoms, treat as myeloma. If there's no myeloma defining events, and if it's a low risk SMM, observe. If there's an evolving change in the M protein or drop in the hemoglobin, you may consider early intervention. And if it's a high risk myeloma, Len or Len plus Dex. So let me give you a flow chart of whatever I spoke in last half an hour. The smoldering myeloma, risk stratified into low risk, intermediate risk, and high risk. We're talking about the progression to symptomatic myeloma. So low risk, for example, the Mayo will be 20 to 20. We've discussed that. Or working group, no high risk fish. And non-evolving biomarkers. So this group will be probably everybody will just closely monitor. High risk, again, 20 to 20, we've discussed that. And the high risk fish or evolving M protein or evolving FLC ratio. So you got three options. You can probably start the treatment, len mono, len dex, combinations, dexa monotherapy, or you put them into clinical trial if they are available, or you still just closely watch, but very closely watch. Not close watch, very closely watch. Last thing you want is a high-risk patient developing a fracture or renal dysfunction before you intervene. And the last thing you want is a person who would have never developed anything for 25 years, getting treatment and either suffering from the treatment, affecting the quality of life, or getting some morbidity, or maybe dying. So all this discussion and the limitations of treating smoldering myeloma in a very homogeneous way is not happening because the risk factors for SMM are poorly defined. And there are therapeutic challenges, as we just saw. Now, this is a beautiful cartoon to explain you whatever I have been talking for last half an hour. So if you, by definition, have a low risk smoldering myeloma, there would be one odd person there who's got a high risk disease. And if you've got a high risk smoldering myeloma by our criteria, you'll have one person there who is low risk. And for intermediate risk, in between. Now, if this group is left alone, without any intervention, without any close monitoring, this one red man can develop bone disease or kidney disease. If we are giving the treatment, more and more aggressive treatment being used, this gentleman in blue is getting treatment for nothing. And he will face toxicity. He'll become resistant to those drugs. And mind you, at the moment, there's absolutely no proof that we are curing any SMM. So therapeutic challenge is that we are under-treating or over-treating a good number of smoldering myeloma by watchful waiting or by giving drugs. Where do we stand today? So let us look at this cross-sectional survey, which has been published. Where we stand today, this is where the hematologists in the whole world stand today. So the question is, observe or control or cure? So this is the study published in Lancet. Clinical preferences on the treatment smoldering myeloma, a cross-sectional study by Rajshekhar, Chakrabarti, and others. This is from Chicago. So, management of high-risk SMM and management of slim myeloma. And people were supposed to respond in this survey. The blue will represent those who opted for waitful, watchful wait, active surveillance. That is no treatment. So blue represents that. Now look here, the blue. So high-risk smoldering myeloma, 90% opted for that they would like to careful watch and wait. 6% went for Lendex and 2% for all other aggressive or Dara monotherapy and all that. As against slim only multiple myeloma, 2 out of 3, 60% went for the myeloma type of treatment. 3% gave Len therapy alone, while 1 out of 3, 37% wanted even the slim myeloma to be carefully observed, very closely observed, and then get into the treatment if CRAB develops. This is where we stand today as per this study. Now look at this study in a different way. Participants' responses based on what is the risk of progression at 2 years for starting the treatment. If the risk of progressing to myeloma was 80%, then good number of hematologists would opt for treat. Or they would not treat at all unless a frank finding of myeloma defining event developed. So 30% here and 25% here, 55% fall, and of course these 10% over here fall in the group where they would start the treatment only if the risk is extremely high at 2 years. Or they will just wait for something to develop and then start the treatment. Those people who will start the treatment with only 20% risk of developing or progressing to overt myeloma at the end of 2 years, it's less than 10%. 40% risk, less than 10%. 50% risk, about 10%. 60% risk, about 10%. So when the risk of progression at 2 years is lesser number of people are accepting, offering the treatment even to high-risk smoldering myeloma. So to summarize and to conclude my today's talk in last 40 minutes, the smoldering myeloma is defined as bone marrow clonal plasma cells of 10 to 60%, M protein in the serum of more than 3 g per dl, or urinary M protein of more than 500 mg in 24 hours, with no myeloma-related organ or tissue impairment or bone disease, and no myeloma-defining events. To this, I may also add no AL amyloidosis. Risk stratification, PATHEMA model, Mayo Clinic model, and IMWG model. PATHEMA, immunoparesis and aberrant plasma cells by flow. Mayo, 20 to 20, and IMWG, including the fish. And you have the low, intermediate, and high risk. If it's high risk, you may put them into clinical trial, you may put them on observation, or you could start the treatment with monotherapy or any other protocol. If it is low risk, it is only monitoring. Intermediate risk, it is close monitoring. This is sum up of all that I bored you for last 40 minutes. Well, here is a lady who from so-called low-risk smoldering myeloma developed a symptomatic multiple myeloma in less than 2 years. She is smiling, but she is saying that she knew 2 years ago that she has cancer, whatever the treating physician might have decided. Well, thank you so much for giving this opportunity to me to speak to you.
Thank you so much, Dr. M.B. Agarwal, sir, for that fantastic presentation. I think that was a very lucid way of presentation and wonderful presentation. The knowledge you have in this field is tremendous, and the way you presented was just cannot have words on it, sir. Thank you so much. Dr. M.B. Agarwal sir just messaged me. He has got some emergency, so he won't be able to join for the discussion. And if anybody has any other question or want to comment or advice, you're free for it. I'll wait for 5 to 10 minutes. And if no questions, no advice, no comments, then we can log out once again and join tomorrow for another meeting or the webinar. So anybody wants to comment or advise or anything?
Hello, I'm Dr. G.M. Kungar. It was an excellent presentation. Very well explained by everything about the smoldering multiple myeloma. What is the current scenario? He has also informed that also.
Absolutely.
Very lucid presentation.
Great presentation. It was a great presentation. One question has just come up from Dr. Rahul. Everybody is free to comment. The question is regarding the use of Len-Dex therapy in smoldering myeloma. So if we give Len-Dex therapy in smoldering multiple myeloma, and if it progresses to overt multiple myeloma further, and someone then decides to go for autologous stem cell transplant, then it has been said that using long-term len can also interfere with autologous stem cell transplant. So can we use lenalidomide in such scenario in case of smoldering multiple myeloma on the initial settings? So anybody wants to comment on this question? Yeah, anybody? Yeah, Dr. Nikhil.
Hi. Again, excellent talk. Listening to MB Agarwal sir is always a pleasure. Wonderful talk, crisp, and covered the entire topic lucidly. So, more of a comment. Many times, I think we fear that if we use lenalidomide, pomalidomide for prolonged time, it may affect stem cell collection. While it holds true for some patients, of late, even patients who have been on prolonged lenalidomide, sometimes even for years, with newer agents like plerixafor, we are able to collect sufficient stem cells. So I think personally, just the fear that we may not be able to get stem cells, that alone should not be a deterrent for treating high risk patients who otherwise need it. I mean, this is just a personal opinion.
True, absolutely. Now, I will just ask you all to raise your hands or just give a pop-up sign. How
I
many
have
of
one question for you, sir. A
yes,
couple of questions actually. In the setting of a smoldering myeloma, if there are high risk cytogenetic abnormalities on fish, like deletion 17p or 1q gain, would that influence your treatment decisions?
that's what I'm putting a hand raise signs. So we have about couple of 20-25 hematologists all over the country. High risk smoldering myeloma detected on fish. How many would of you will go for treatment? Just put a thumb sign. So I think you have 1%. So out of so many, one. And how many of you will not go for the treatment? If you are detected high risk smoldering multiple myeloma
With a deletion 17p.
with deletion 17p, or you got amplification of 1q. So I think the house. So how many of you not go for the treatment? You can just put a thumb sign. High risk smoldering myeloma. Okay, so most of them are going for no treatment, even in 2025. So I think the time will only say whether we should treat this high risk smoldering myeloma in future or not. So at present, I think most of them agree that we are not treating high risk smoldering multiple myeloma. There are some people who are also commenting, I would treat. So okay, so it's just I may say 70%, 30%, 70% no treatment, 30% will treat now.
And my second question, sir, in a high risk smoldering myeloma, with before labeling the patient as smoldering myeloma, if we have to rule out lesions, especially very small lesions in the spine and other things, what should will a PET CT alone suffice, or should we also do a MRI of the spine? Because very often, very small lesions can be missed on a PET. So, is a whole body MRI or a spinal MRI mandatory before we say there are no skeletal lesions and label the patient as high risk smoldering myeloma?
Again, a very great question. And I would like to comment on this question, what you put up. I think we have got two criteria. One is on WHO criteria that it's mentioning about CT and PET CT scan. And IMW says about MRI. And when I talk about MRI, it is IMWG. And if it is two or more than two focal lesions on MRI, it will set into definition of myeloma. But if it is one or more than one lytic lesion on PET CT or CT, according to WHO, it will go into definition of myeloma. So I think if your PET CT doesn't pick up, then you are mandatory to go for MRI to prove that there is a two or more than two focal lesion defining your myeloma defining events. So yes, PET CT and MRI both should be the imaging modality of choice, because if your PET doesn't pick up, MRI should be able to pick it up. If anybody wants to comment on this regarding PET CT, CT, and MRI, please be free feel to advise or comment on this.
And a lot of lot of buzz on CXCR4 PET CT scan and other imaging modalities. I just wanted to know, in routine clinical practice, is anyone using a CXCR4 PET CT scan anywhere?
So, anybody is using? No. No. No from most of them. No. Right.
Okay, sir. Wonderful discussion. Thank you so much for the invitation.
Thank you. Thank you, everybody joining over here. And once again, big thanks to Dr. M.B. Agarwal, sir, who just spared time to record his session today. He had some acute emergencies, so he had to rush for the same. So he could not join for the discussion. Otherwise, we would have a wonderful discussion with Dr. M.B. Agarwal, sir. And we all know that. Once again, thank you so much, all the discussions. And I also thank all the audience joining over here to spare their time and for this webinar. That was a beautiful webinar, beautiful presentation by Dr. M.B. Agarwal, sir. And meet you tomorrow at sharp 11:30 a.m. with another beautiful webinar. And that will be by Dr. Shankara Panisha from UK. Thank you once again. Thanks a lot. Goodbye for now.